Well, thank you, and thank you for having me. My talk is really going to cover two themes, one of which is my experience using ketamine clinically in a private psychiatric practice over the past 10 years, and then also an explanation of the obstacles that those of us who do ketamine have always found in trying to disseminate this technique. And unfortunately, these obstacles, I think, equally apply to any plant-based entheogens and MDMA, so I think we need to at least understand them to develop strategies to overcome them. I've long been interested in trying to make ketamine widely available for people who have insurance that could afford it. It's at this point not really covered by insurance, and that's a real challenge, and that's one of the things I'm going to talk about. Okay. So I'm going to discuss the use of ketamine based on our experience with 300 patients over the past 10 years, at least 4,100 IM, IV, and sub-Q treatments. We've also used a lot of home ketamine in the form of troches and intranasal ketamine. Just briefly touch on ketamine and a broad range of treatment-resistant psychiatric illness, and then discuss obstacles to the broad dissemination of ketamine. So in 1999, I became interested in a treatment that was called narcotherapy that Dr. Langer had developed. This involved using high doses of a halothane anesthetic agent as an alternative to electroconvulsive therapy. And I replicated his results in 700 treatments and 70 patients in 2 studies. But like Dr. Langer, found it impossible to disseminate this treatment, which unlike electroconvulsive therapy does not have any memory side effects. And when I started doing this research, I kind of had the naive expectation that if you found a useful treatment that was superior to other treatments that were available, that the world would beat a path to your door. That was it. You invented the best mousetrap, but it wasn't that case at all. Later on, in working with a lot of anesthetic agents, I stumbled across another treatment that is also equally very effective for PTSD, involving using sedative agents. Pardon? Talk close to the mic. I stumbled across sedative facilitated psychotherapy. We used propofol, frequently amytal and pentothal had been used, and like the old literature showed, this was a very effective treatment that could treat the active flashbacks, nightmares, hypervigilance of PTSD within just a few hour-long sessions with the anesthesiologist. But this treatment had gone completely extinct around the time of the Vietnam War, and I'm going to discuss some of the reasons why that happened. There's no reason why this treatment can't be done today, except for the payment codes are outdated, but people have stopped doing it, and stopped doing it so completely they've forgotten about it. Okay. At Baylor, I was geared to find something like ketamine because I already had the experience with sevoflurane that patients could have an immediate response to a drug-based treatment for depression. And ketamine didn't work the way I thought it would, but it worked very well. I started doing it with a pain doctor there, using it with patients who had pain and psychiatric illness, seeing the same robust effect that Dr. Zarate reported in his article in 2006. And I realized based on my experience that there would be more call for more research on efficacy, but that it was extremely efficacious. There's, one of those treatments that, as you say, you don't really need statistics to see the effect. But that the real challenge would be disseminating it. We were getting the cost of the treatments covered just by Methodist Hospital eating the cost. And I called every government agency I could think of to see how we could get the cost covered so that Methodist would continue to provide it. And I finally ran into somebody at the Center for Medicare and Medicaid Services who told me that there is no government agency that has a responsibility of promoting treatments simply because they're helpful and could help people. And I was kind of surprised at this. The only thing that's remotely similar to this is the Orphan Drug Act, which was passed years ago to defray the costs of drugs for very rare conditions and to make like drugs for Tay-Sachs and diseases like that available. But unfortunately, this didn't apply to ketamine. And of course, insurance companies are not in the business of extending benefits or inventing treatments. They rely upon the pharmaceutical companies and their cadre of sales agents and personnel to call them up and twist their arm and use their contacts to get the drug on the formulary before the drug actually becomes available to the average psychiatrist. So these are some of the facts about how treatments are disseminated that I'm going to cover a little bit, because we need to think about these for things like MDMA facilitated psychotherapy for PTSD, which is the most effective treatment for PTSD available now, but is going to face some substantial challenges, as is psilocybin. In 2008, I went to visit the only person in the country that I was aware of that was trying to provide ketamine on an ongoing basis in a private practice, Dr. Eli Kolp in Tampa, Florida. Dr. Kolp is a very interesting fellow. He's a Russian psychiatrist who had collaborated with another Russian psychiatrist, Dr. Evgeny Krupitsky, who had found that ketamine psychedelic therapy was a very effective treatment for alcoholism. And the LSD therapy for alcoholism was very effective years on, but of course was no longer available, and ketamine was the only other psychedelic agent available. And after running into the usual roadblocks that we've all run into at medical school, he went into private practice and tried to provide it there, but unfortunately couldn't get it to go. And so here was a guy, the only guy that I knew of that was trying to disseminate this treatment, who'd been working on it for over 10 years, who'd not had any success. It was kind of a little bit discouraging. I began doing IV ketamine therapy at Cottage Hospital, but then shortly incorporated IM ketamine therapy and sub-Q therapy in my private practice, which is what I do nowadays. So I'm just going to briefly mention this treatment in case there are any philanthropists who would like to support research into developing it. That when we do electroconvulsive therapy, the machine produces a seizure, and the seizure comes to a point where it stops abruptly and there's a period of suppressed EEG activity. Now, Dr. Langer's insight was that using a high dose of a conventional anesthetic agent would produce the same pattern in the EEG. And so it wasn't the seizure, it was the suppressed EEG activity that was responsible for the therapeutic effect. And I replicated his results. In fact, he was right. It worked just as well, maybe a little better than ECT. Was a great treatment. Patients loved it. We transferred, we treated many patients over the course of a few years, but could not get it to disseminate. And I actually called Dr. Langer and asked him why and what his experience was, and his experience was the same as mine, that he worked with it for over 10, 15 years. He always was enthused about it, thought it should catch on. Nobody wanted to learn how to use it. There was no financial incentive to develop it, and nobody else adopted it. And when you think about it, that's a real disturbing thing. Now, I also had the opportunity to treat post-traumatic stress disorder with the anesthesiologist using a technique that I call facilitated psychotherapy. And you remember back in 1983, Joseph Ledoux began studying fear conditioning as a model of post-traumatic stress disorder. And with fear conditioning, you pair a stimulus like an electric shock with something like a tone or a light, and this is in a rat model. And the amygdala is involved in developing a fear memory, and the fear memory produces activation of structures in the brainstem that, among other things, produce freezing. Okay, and this is why we have difficulty doing post-traumatic psychotherapy with patients with PTSD. Is that when we begin to trigger the fear memory, they become extremely anxious. They're very uncomfortable. They frequently hyperventilate and freeze, and they're unable to develop an extinction of the conditioned emotional response, the fear memory, okay? And so I used propofol to treat a patient with this quite effectively, and did a small series of patients with this. But again, could not interest any colleagues to do it. It was a struggle to do it in the hospital environment. The treatment that could be done any day right now for PTSD is very safe, and there's extensive literature on it, but it's gone extinct. Okay? So what a puzzle. So facilitated psychotherapy has also gone by names narcosuggestion, narcoanalysis, or Amytal or Pentothal interview. And it's basically psychotherapy facilitated by sedative agents or other drugs. It has been used since World War II to treat conversion symptoms and post-traumatic stress disorder. It went out of use and is rarely used today despite clear efficacy and rapid response. And one way of saying that why this happened is that around the time of the Vietnam War, psychopharmacology was a new and developing science. It seemed much newer. This seemed like an old-fashioned technique. We didn't understand what was going on with PTSD. Psychiatrists don't go into psychiatry to do interventions in the OR, and for all these reasons it went extinct. But striking that a very effective treatment that will go extinct and get replaced by something that's inferior, okay? Now, practical aspects of ketamine therapy, apart from screening and medical evaluation, monitoring, Informed consent, luckily Dr. Culp gave me a copy of his informed consent, which I modified for use with low-dose ketamine for depression. Financial aspects, well, how do you get it paid for? Well, most people unfortunately have to cough up $500 to $600 a treatment, and there are very few people that can really afford that cost. And they often want they often do 6 treatments to get a remission. And then it usually requires some maintenance treatments after that, which prices it out of the range of availability for most of us. The spacing and number of treatments is important. I started out treating patients intermittently. Well, initially I did a series of 6 treatments in a couple of patients, but then I have been doing just one treatment, judging the effect, and then getting the next treatment to prevent relapse. And very importantly, collaborating with a psychologist to have appropriate and effective psychotherapy to go along with the ketamine. The main focus in the ketamine session is creating a sense of safety, as John Bowlby referred to, a secure base, a sense of a spiritual journey. Start with a low dose, 0.5 milligram per kilo, and gradually increase as tolerated. The IM injection causes a peak effect within 30 minutes. Usually you can set your clock at 20 minutes after an IM injection. Patients are mostly recovered by an hour and generally ready to go home by 90 minutes. Now, strikingly, we noticed that 5 patients who'd always had a robust effect for pain or depression or other symptoms, very strikingly did not have an effect when there was an issue involving attachment insecurity. Okay? For example, one patient was brought to treatments by a female aide that was basically her only friend, and this aide had been accepted to nursing school out of state and could no longer bring her. Another patient had learned from his wife that she intended to divorce him. Yet a third patient discussed a traumatic relationship with her father coming out from under the influence of ketamine. So this kind of got me interested in attachment theory that I didn't know too much about. And I'm going to just mention this briefly because this is one of the important aspects of psychotherapy with ketamine, and I presume with other psychedelics. I'm just going to briefly talk about the effects of ketamine on the brain. One thing, this is an old study from a group at Yale showing that when we are chronically stressed, we tend to go into glutamate overdrive, and the spiny neurons of the brain, this is a spiny neuron dendrite or axon, the spines withdraw and the brain kind of disconnects. And ketamine actually causes the brain to rewire itself by actions initially as an NMDA receptor antagonist, but then later on a protein called mTOR. So basically the brain rewires itself, okay? And I think there's some evidence with some of the other psychedelics that this happens, so it's a perfect opportunity to begin to try to do the right type of psychotherapy to promote the right kind of learning to facilitate recovery. Attachment theory was developed by a psychoanalyst named John Bowlby in the early 60s, who collaborated with a woman named Mary Ainsworth. And his college roommate was this guy, Harry Harlow, who did these rather cruel studies with rhesus monkeys. You've probably seen a picture of rhesus monkeys clinging to a cloth representation of a mother, a wire representation of a mother. They did something called the strange situation, where they would have a 2 or 3-year-old child with their mother in a room. A stranger would come in the room, the mother and the stranger would play with the child. The child would leave the room for about 5 minutes and come back, and they just simply recorded what happened during the period of separation and reunion with the mother. And they found that they could identify 4 different patterns of behavior that were reproducible, and if they looked 6 weeks down the road, they tended to see the same pattern of behavior. About 2/3 had secure attachment, and the other third had one of 3 forms of insecure attachment. Okay, there was a correlation between the attachment patterns that they had developed at 2 and 3 years of age and what they had 20 years later. So the attachment schemas that we form in childhood, that we begin to form before we even are verbal, serve as something of a template for our relationships and expectations of other people later on in life. And more recently, there's been research demonstrating that developing the mentalization ability, the ability to look into the world from the perspective of someone else's mind, and knowing what their intentions and emotions are and so forth, is a skill that's developed within the context of being cared for, and then helps us develop these attachment schemas. And this is kind of a backbone of emotional self-regulation, so that if you have an insecure attachment schema, you're more susceptible to depression, anxiety, addiction, and so forth. And Psychotherapy in general will activate attachment schemas, and particularly psychedelics will do that. And so that it's an opportunity to mold the insecure attachment schemas in the direction of security. Okay. Set and setting. Okay. Those who are old enough may recognize this cartoon from the fabulous Furry Freak Brothers, which was a head cartoon back in the 70s. And these were three hippies who took a trip to visit Franklin's decadent cousin in, of course, Los Angeles. And instead of getting cocaine, they got ketamine, and they ended up seeing bats all the way home. Okay, so the job you want to do during a ketamine session is to try to keep the bats to a minimum. Okay, and you do this by having a good bond and having security and not having bright lights and having good soothing music and having the patient know that they can trust you. In some settings, about 14% of patients who receive ketamine for anesthesia have what's called an emergence reaction. A lot of fear and anxiety and so forth. It's really kind of traumatizing when they come out from the effect of ketamine. We basically don't ever see that. You know, if you really control the setting, I think you don't have that. One of the things that people say, pharmaceutical company representatives and so forth, of why we don't want to get ketamine out there right now is that we need more long-term data. What they don't say is that every drug that's on the market that is routinely used every day for treatment-resistant psychiatric illness does not have any long-term data, because drug companies are in the business of selling drugs, and they do the minimal amount of research to get the drug out there, and longer-term studies are hard to fund, and there's a high dropout rate, and basically there is no long-term data for virtually any of the medicines that are used every day for treatment-resistant mood disorders. So this is a small cohort of patients that I've treated over several years with as maintenance therapy for pain and depression and so forth with no complications. Everybody I know that does ketamine has some collection of patients like this. And what do we see? Well, we see mood disorders. Bipolar and unipolar is probably the most common. We see a lot of PTSD, which is important because PTSD is otherwise very, very hard to treat. There's really no medicine that's a magic bullet for PTSD. Several forms of chronic pain, complex regional pain syndrome. Sometimes it'll work for one form of pain and not do anything for another form of pain. So I don't know why it works for some forms and not for others. Borderline personality disorder, occasionally it'll help that quite a bit. Social phobia can respond. Krupitsky and Kolb's work in the 90s demonstrating effects on addiction showed a pretty striking effect. In Krupitsky's study at the Moscow Narcological Institute, he took 100 alcoholics that were hospitalized for a 30-day alcohol treatment program, gave them 2 sessions of ketamine psychedelic therapy, a higher dose than we typically use for mood disorders, compared them to another 100 patients who had the same rehab program but didn't have the ketamine psychedelic therapy. The ketamine group, at a year, over 70% of them were still sober, which is a striking effect. Slightly more than 20% who had the program but didn't have the ketamine were still sober. So, you would expect that our alcohol researchers would be following up on this. They haven't, okay, which I think reflects kind of a bias against interventions in our research community. Palliative care, end of life. I think this is an important area where ketamine has a really important role, and I've been trying to get some of the palliative care programs, the hospices and so forth, to adopt it, but it's hard to get it to be introduced. So targets for psychotherapy are attachment, the conditioned emotional responses that are part of PTSD, avoidance behaviors, schemas. Jeffrey Young developed a type of cognitive behavior therapy called schema therapy that's particularly helpful. Mindfulness skills, compassion-focused cognitive behavior therapy is developed by Paul Gilbert, and metta meditation, and reconstructing a life narrative. Okay? And there are really kind of 2 aspects of this that I'm going to highlight here. One is that many of the effects that we get from trauma or pain or so forth involve kind of rigidifying our responses, that there are barriers to responding flexibly in the nervous system. And part of the work that we do is removing those barriers. Okay? Another part of it is developing the part of the brain that's involved not in producing automatic behaviors, but in non-automatic behaviors, in the attention system, mindfulness, and so forth. I'll come back to that in a minute. The psychedelic experience with ketamine is grist for the mill in terms of using it to help understand and treat people. when I went to see Dr. Culp, and he gave me 150 or 50 milligrams per kilo of ketamine, I had a rip-roaring psychedelic experience, and I had a state of ego dissolution. I remember losing track of who I was or where I was, and having a body, and I felt like I was just a spot on this roiling sea of consciousness. And I had a couple of visions that were very meaningful, and I sought to find some pictures to represent that, to use that as an example of how to use the psychedelic content. And this was one of them. So I saw this network of lights, interconnected lights on a peninsula. About 10 months later, I realized it was the state of Florida, of course, where I was at the time because I was in Tampa. I didn't realize it at the time when I had the vision. And it was somehow conveyed to me, or the thought I had, was that each node of the network represented a human life, and thought of all the suffering that's inherent in our lives. And the connections between the lights indicated the fact that we have to connect, we have to forge bonds, and come out of our isolation in order to bear the suffering. In fact, that was the function of pain, which I think is a good lesson. So, getting into treatment, obstacles to treatment dissemination. First of all, treatments can be considered to be memes. And memes, you know, that's a term that was introduced by Richard Dawkins to refer to pieces of information that act like genes in following the Darwinian algorithm of variation, selection, and reproduction. There's an area called diffusion of innovation theory, which concerns factors associated with the success or failure of adoption of an innovation, just generally. So if you're trying to get Peruvian villagers to boil water to prevent river blindness, for example, you're not going to be successful if they have a belief that the fire demon will jump into the water and make them ill. Okay, so that the culture and other factors are important. The profitability of a treatment is a factor. Convenience, how compatible is it with the training and worldview? These are all factors that can go in favor of or against adopting a treatment. So several factors other than utility affect the success or failure of adoption. This is particularly true in institutional settings. Okay, institutions have a concern about medical legal risk. This is why the VA and hospitals have not yet adopted ketamine. Kaiser in Northern California has adopted ketamine. I have a friend in Hawaii who's been trying to get ketamine through their protocol for about a year. And if anybody deserved to get ketamine, she did. So that when we have the triage and prior authorization mechanisms that insurance companies are fond of using, it probably is going to cripple access, unfortunately. So good treatments can fail to be adopted, they can go extinct, or sometimes they can even be replaced by inferior forms of treatment. So you think of this as being like an ecosystem, an evolving ecosystem. That these are factors that occur with an evolving ecosystem. This is an example of a plant that you see down south called kudzu, okay? And this is a particularly invasive vine. The vector for this vine were people that were actually planting it to control erosion, and it has a growth rate of about 1 foot per day. So it's crowded out all the other biomass in the area. And this is what newly patented pharmaceutical agents do to treatments in our marketplace. They have a cadre of personnel that are well trained in getting the insurance companies to add this new medicine that typically costs $800 to $900 a month. And nobody else has that. And insurance companies are in the business of limiting treatment, not extending it. Okay? So that's a real big problem. Point 2 is the difference between mechanical versus living systems. And this is a confluence of the diffusion of innovation theory that I think we ought to know when we're trying to disseminate treatments like psilocybin. And also another area called complexity science that is fairly recently developed. Okay? But it's obvious what the difference between a cat and a clock is. Okay? A clock is fairly rigid, predictable. It's black and white, explicit. You can control, you can bet what it's going to be doing an hour from now or a day from now. Not so with the cat, okay? The cat's, on the other hand, much more flexible and adaptive, probably has a better understanding of the world and the challenges that are faced than the clock. And in healthcare, we have these two poles of the system, okay? And unfortunately, the mechanical pole wins out, and we neglect the living pole. Okay? So mechanical or simple systems are precise, explicit, rigid, and predictable, are insensitive to context and inflexible, And I think of these as the robot view that we adopt when we do science, when we do medical practice, law, and organizational regulation. And living or complex adaptive systems are imprecise, implicit, adaptive, and unpredictable. They are sensitive to context and nuance, flexible, when we put on our human glasses, this is the form that we adopt. Of course, we're all born with the living view, and to become scientists, we learn over and over again the mechanical view. So I'd like to leave you with a consideration of a term, Neovitalism, which is a reintroduction of a dead philosophy, which emphasizes really the importance of having the human living perspective on things. Descartes, developing the scientific method, dissected animals and saw the parts of the body, like the hip joint, were obviously mechanical. They were like the clocks and mechanical ducts of the time. And he instituted a tradition in science of making mechanical models of everything because they're predictable. And that's what we do scientifically. We think of things in terms of mechanical models. He excluded res cogitans, the mental functions, as being the province of the church. And so we developed this trend toward reductive materialism, of thinking of a clockwork or billiard ball universe. Leibniz was a factor here. Bergson, a philosopher in the 20s, introduced the term élan vital, but then this viewpoint went extinct until about the mid-'80s, when with the advent of high-speed computing, it became possible to model some of these living systems, which technically are referred to as nonlinear dynamical systems using something called Monte Carlo techniques. And the Santa Fe Institution is a place where people from fields as diverse as economics and biochemistry and city planning came together because all three of those areas concern complex adaptive systems. So Neovitalism stresses the importance of this perspective. So, and this is important with several aspects of ketamine therapy. Dissemination, because healthcare is a complex adaptive system, and the psychotherapy, certainly we open up and connect the mind, and there's growth and adaptation and a living event that happens with ketamine, ketamine's effect on the brain, and the psychedelic experience. The good news is that there are all kinds of treatments that we could use if we could put down our robot glasses and use something else. Not only ketamine, but multiple treatments for chronic pain. I've already mentioned the halothane, isoelectric therapy. Facilitated psychotherapy for anxiety disorders, when extinct, could be used today. There's a technique called stellate ganglion block for PTSD, so forth. So with that, I'm going to conclude, and I don't guess I have any time for any questions.
Thank you, that was awesome. Hopefully this is a good question. I was wondering how long after ketamine takes effect is it appropriate to have the psychotherapeutic intervention?
Well, because of my experience with patients touching on painful topics, losing the effect, I usually think of doing it certainly much later in the day or the next day. But then exposure-based therapies have been very, very helpful. And exposure is a key element of most of the anxiety disorders. I think it's neglected in many aspects of many psychotherapy. Therapies are actually provided.
As you mentioned, Kaiser Northern California is doing clinical trials, not in Southern California. But I understand from a Kaiser psychiatrist that FDA is looking at a nasal spray, which they think they might approve next year.
Yeah.
Do you have information on that?
Well, this is S-ketamine, which has been available in Europe for quite some time. I'm very skeptical that this is going to be superior to IM and sub-Q ketamine. In fact, I'm really worried that this will be a case of an evolution of an inferior treatment that will capture the market, but displace the more effective IM and sub-Q treatments that can be provided. It will probably almost certainly cost about $1,000 a month for a treatment. And it will have the advantage of the Johnson & Johnson pipeline to get it out there and marketed. Since the antibiotics, we've all been conditioned to think that the best treatments in medicine are newly patented drugs. And that's not always the case, not only with ketamine, but with some nutritional supplements and so forth, types of psychotherapy and so forth. Let me say just a word about MDMA psychotherapy, which is very effective, but faces several challenges. MDMA is a Category 1 drug, so it's not like ketamine is a Category 3 drug, so it has to be reclassified. It's a one-shot deal, so how are you going to monetize that? The psychotherapy component is a very important part of it and requires specialist training. And how are you going to disseminate that and get that out there? You know, it's hard enough to get some of the effective forms of psychotherapy to get them out there. It should be out there, but this is a problem that we need to think about in revising. Ketamine has shined a spotlight on how we should be selecting and promoting treatments. Yes.
So what does ketamine therapy actually look like? Is it conversational, somatic, experiential? Can you maybe...
Well, it kind of depends upon the indication. In the list of conditions I showed you there, every patient I see probably has at least 2 or 3 of these, okay? And most of them have some evidence of an empirically supported form of psychotherapy being helpful. So I try to select psychotherapies that have evidence of helping. But like with PTSD, I had a patient, for example, who part of original trauma involved being bitten by rats because that's what a tormentor would do. So anytime she was in the presence of a rat, she would have flashbacks, hyperventilate, and so forth. And the day after ketamine, I told her to go to a pet store and pick up a hand of rats, which she, of course, never been able to do. And she was able to self-expose and get past that particular flashback and trauma trigger. So there's the generic, the good psychotherapy begins with a good attachment bond, but it doesn't end there.
Okay, I'm sorry, that's all we have time for. Thank you, Dr. Early.